Recording. So this is Winston Guathamy. I want to say thank you to everybody who's coming to our virtual curriculum. It's been great so far. I think that everybody's gotten a lot out of this so far. I've gotten a lot of positive feedback. Our department's trying to do our best to make sure that we do really two things. One, provide some orthopedic education. I know it's kind of a funny time for you all, and I just want to make sure you guys get at least some degree of education during this process. But two, also try to highlight our program. And the two things we try to do is one, highlight our faculty, and that's why we've had a faculty member give a talk each time. Highlight our residents, and that's why we'll have a resident do a case presentation as part of this. And then finally, highlight our program. And tonight we're going to be talking about Ivy Mountain, which is something we're really proud about. And I know that Dr. Chhabra is very excited about sharing some of his thoughts about that. At the end of this session, Dr. Chhabra, our chair, has been gracious to offer a Q&A. So if you have any questions you want to ask our chair during this process, you can put them on the chat board and you can send them to me. Otherwise, you can ask them directly if you feel brave enough. But like I say, I like to keep this pretty prompt. If possible, keep it within 1 hour. I'd be okay going a little late tonight since we have Dr. Chhabra who's going to grace himself with his time. So we might go a little bit late tonight. But without further ado, I want to introduce Dr. Freilich, my good friend and partner, who's a hand surgeon here in the hand division. We're going to highlight scaphoid fractures tonight, and he's going to talk about the hand division a little bit. So thanks again for everybody for coming. Dr. Freilich, thank you for doing this, and we'll have some fun tonight. So Dr. Freilich, the floor is yours.
All right, thanks, Winston. I really appreciate it. Thank you guys all for being here with us today and sharing your evenings or earlier, depending on where you are. Today I'm happy to have the hand division and my partners with me, so we can do a little bit of teaching, talk about scaphoid fractures. The hand division is me and my other partners, Dr. Nicole Deal, Dr. Richard Dacus, and of course our chair, Dr. Bobby Chhabra. And so we're obviously here. We all love teaching and we're happy to have you. And without further ado, I'm going to talk a little bit about scaphoid fractures. This is going to be fairly brief, relatively basic, an introduction, and then one of our chief residents, Dr. Michelle Q, who was nice enough also to assist me with some of the slides for this talk. I really appreciate it. We'll be going over two cases, and hopefully that'll generate a little bit of discussion. So here we go. So scaphoid fractures, the reason I selected this as one of the options is it's a fairly common injury that we see, and when it's not treated, it can be somewhat devastating. So we see these mostly in younger patients, which is not surprising given that they're mostly relatively high energy injuries. So people falling off skateboards and the like. So the peak age is going to be between 10 and 22 years old. So these are going to be younger patients with better bone, and generally a male predominance. Again, not surprising. Most recently, people have said there's about 2.5% of all wrist fractures each year. So, and there are all close to 1 million wrist fractures each year. So it's quite a lot of fractures that we see in the United States. Prior estimates were as high as 12%, but still 2.5% of all wrist fractures is pretty high. So how do people get these? This is almost always some sort of a fall on an outstretched arm, whether high energy or low energy. And you end up with hyperextension, radial deviation, and essentially you get the crack at the scaphoid waist most of the time. If there's some dorsal subluxation, obviously the pattern can be a little different, and you can end up with a proximal pole fracture as well. What about associated injuries? So you need to think about this as you evaluate these patients. I will warn you that if you ever get a phone call from the emergency department and they say, hey, I've got a really displaced scaphoid fracture, I'm going to put that into a splint and send it out to follow up with you, is that okay? You need to at least look at the films and make sure they got good films, because most of the time, if not all the time, a very displaced scaphoid waist fracture, more than a couple millimeters, is going to have some sort of other ligamentous injury or be associated with like a perilunate, so some sort of a transscaphoid perilunate variant that needs to be reduced urgently as opposed to just sent out in a splint. And I think that's how some of these are missed. So make sure you are aware of other injuries like ligamentous injuries, scapholunate or otherwise, perilunate injuries. Other carpal fractures, such as the capitate or the hamate, can certainly be associated with these. And like I said, carpal dislocation as well. So what do you do when you see these patients and you get called about them? So physical exam, this is fairly classic. So obviously you're going to have pain, swelling at the wrist. Classically, they'll have snuff box tenderness, They will also tend to have pain in the radial wrist and with radial deviation. Other tests that are helpful in terms of trying to figure out, is this something simple or is this actually a scaphoid fracture? Excuse me. Is going to be scaphoid tubercle pain, so pushing on the scaphoid volarly, and then pain with compression of the thumb if you're unsure. And so here's a chart just talking about the sensitivity and the specificity and the positive and negative predictive values of each of these tests. And if you include enough of these tests, you get a higher sensitivity and specificity, and you're more sure about your diagnosis and about the problem. So what do you do when you suspect a scaphoid fracture? Imaging and certainly x-rays are going to be the first step when you evaluate these patients. And just a classic series is going to be a PA and a lateral navicular at the very least. That's what you want to get. The navicular view gives you ulnar deviation. It tends to stand the scaphoid up and gives you a better view of the entire scaphoid without the tubercle overlying the remainder of the scaphoid. Makes it easier to see fractures of the scaphoid. You also want to consider getting a clenched fist view, simply because they can be associated ligamentous injuries, or what you think is a scaphoid fracture could be a scapholunate injury, and it's nice to have that clenched fist view to make that distinction at that time as well. The reason this matters is that a percentage of scaphoid fractures, especially what are called occult or non-displaced scaphoid fractures, will not show up on initial radiographs. And so the combination of a radiograph, which may diagnose it, but if it doesn't, and the exam is really important for treatment, especially initial treatment. So here's kind of a little bit of an imaging algorithm. This is how I end up treating them. But if the x-rays show the fracture, then it's pretty simple. You treat them as appropriate based on the fracture. However, if they don't, but you have a relatively high suspicion for the fracture and you can't see it, you can certainly consider an early MRI. There's several studies that have demonstrated the cost effectiveness of doing an MRI to make that diagnosis or rule out the diagnosis and allow those patients to get out of a cast or out of a splint and back to work quickly. Your other option is to splint them, so that's important. You need to immobilize them in a thumb spica and then re-image them in a week. At that week, you may have the diagnosis, which again, if you do, then you're done and you can make the decisions based on the appropriate treatment. If it's negative at that point, either you have to consider an MRI or you can consider casting for 2 more weeks, so a total of 21 days, and re-examining and re-imaging at that point. Unfortunately, sometimes you get to the point where at the end of 21 days, they still have pain. Sometimes that happens, the patient's a little bit unreliable, and you may end up getting an MRI at that point anyway if you can't figure out why they still hurt. But if they're non-tender and they have negative x-rays at that point, it's probably okay to get them moving. MRI, what about MRI? So again, it's useful to identify occult fractures. It's certainly useful for ligamentous injuries, and it's useful for assessing the vascularity in the case of non-unions. CT scan is also useful, especially acutely. And it can be used to identify the degree of fracture displacement. We'll see that a little bit in one of the cases later. It can demonstrate the amount of collapse or the fragmentation of the fracture, any cystic changes in the case of non-unions. And importantly, it's used to demonstrate the progression of union or non-union after treatment, including after surgical treatment, where CT scan has been shown to be more reliable, better, and to detect union earlier than simple x-rays after fracture fixation or after non-operative treatment of a scaphoid in a cast. So how do you evaluate the imaging? Obviously, we showed the x-rays, but you need to be able to look at it. If you see the fracture, that's great, but you need to know what's going on. You need to evaluate it on the navicular and the lateral, look for a degree of displacement. You want to look at the scapholunate angle as well. That will give you an idea of scapholunate ligamentous injuries, but as well as this humpback deformity that you can get with non-union of the fractures. It's important to note that so they can be treated appropriately. The better way to check for humpback deformity is the interscaphoid angle demonstrated here. So you can see with this chronic non-union that they have a humpback deformity. So again, the back looks like a hump because the scaphoid is flexed. And that's going to go on to non-union, and if you try to fix it there, it's probably not going to heal, versus this angle, which again looks normal. So none of that's very surprising, but those measurements, in addition to the standard measurements of displacement, will give you an idea of what's going on with the scaphoid and how to treat it. So what about treatment? So it's a little bit of a grab bag here on this slide. And this runs the gamut between non-operative treatment, so stable fractures that are non-displaced, so less than 1 or 1.5 millimeters of displacement can certainly be treated non-operatively and can be treated non-operatively successfully. Operative treatment can still be done for stable fractures, and there's a compelling reason sometimes to do that for certain patients. But usually these are used for displaced fractures, so greater than 1.5 millimeters. Again, athletes and laborers, because you have the option of getting them on a cast and returning to work. Associated ligamentous injuries, so perilunate injuries with associated transcaphoid fractures can be treated operatively because you're going to be treating the ligament operatively as well. Unstable fractures, such as proximal full fractures, really should be treated operatively. They tend not to heal, even with cast treatment. And then chronic fractures, so non-unions, need to be treated operatively, as they've already proven that they're not going to heal. So here are some of the treatment algorithms. Non-operative treatment is a short versus a long arm cast, usually thumb spica, and then casting until radiographic union, either on X-ray or on CT scan. And you can see the difference depending on where the fracture is, either distal, middle, or proximal third fractures, and how long it potentially takes with a proximal fracture, which again is why those are treated operatively. In operative treatment, you have a bunch of different options as well. So percutaneous screw fixation through a relatively small incision or mini open incision, mini open approach can either be done dorsally. So certainly for proximal pull fractures, that gives you the best chance of putting the screw in the right position. Volar approach is an option for distal or waist fractures, although there's certainly an argument as to the best approach for scaphoid waist fractures, and we can talk about that later. And then open reduction internal fixation. So if there's a humpback deformity or significant combination of displacement, either percutaneously or more likely open, the fraction needs to be reduced before it's fixed. If you fix it in a humpback deformity, that's certainly a recipe for a non-union. And that's one of the reasons that you either don't get a proper screw placement, or the fracture goes on to non-union despite fixation. And certainly that can be combined with bone grafting, either vascularized or non-vascularized at that point. So what about non-union? We've talked about this a little bit. The problem is that chronic non-unions of the scaphoid lead to SNAC risk, so scaphoid non-union advanced collapse, and then eventually a fairly predictive pattern of arthritis, and then you go from having a young person with just a broken scaphoid that can be fixed to a wrist that potentially needs to be fused, which is obviously a problem. The reason for the non-unions in these patients are because of avascular necrosis, or AVN, which you can see on this MRI from this paper that was put out by our radiologist, Dr. Chhabra. And that can be evaluated on MRI or with CT scan to look for sclerosis of the proximal pole. And the reason for the AVN, of course, is because of the unique vascular supply of the scaphoid, where all of the blood supply is coming in a retrograde fashion. So a fracture further away from blood supply results in more disruption to that vascularity and, unfortunately, avascular necrosis due to that fact. So that's kind of my breeze through the scaphoid. What I wanted to finish with is a slide a little bit about some of these controversial issues that I purposefully didn't really give you an answer to or discussion on. These are things that still at the Hand Society are discussed at course lectures and argued about by various experts worldwide. And we can talk about some of these things a little bit as we do some of these cases here in just a minute. But the first one is short arm versus long arm cast. Which one is appropriate for non-operative treatment? You would think that would be settled by now, but it doesn't seem to be. The question also is CT scan versus MRI. So certain sequences can certainly show AVN, but there are some people that believe that the MRI can potentially oversell it, and maybe just a CT scan is best, and it doesn't correlate. I think that depends on your radiologist and how you do the MRIs. Vascularized versus non-vascularized bone grafting for AVN, interestingly, is a continued point of argument as to whether or not you actually need to bring blood supply in with your bone grafting for AVN. And then the type of vascularized bone graft. Do you take it from the knee? Do you take it from the wrist? Do you take it from the metacarpal? Do you take it volar? Do you take it dorsal? I think they all have compelling arguments, and we continue to argue about them. 1 or 2 screws is another controversial issue, or will become a controversial issue, I think, as more and more people do this. There was one of the articles that was shared talks about this, and we can talk a little bit about that later as well. And then where do you put the screw? Do you put that center, or do you try to get perpendicular to the fracture for best fracture fixation and compression in order to heal it? So that's what I have for you guys, hopefully to stimulate some further reading and certainly some discussion as we go through these cases. Without further ado, unless there are any immediate questions here, which I'm happy to answer, Dr. Q will go ahead and start going over some of these cases and we can discuss them.
Hey, thanks a lot, Mr. Freilich. Perfect stuff. So Michelle, are you there?
Yep, I'm here.
Awesome. The floor is yours.
All right. All right, so I'm going through two cases that have kind of a different presentation and treatment algorithm. Just kind of show you what we do here at UVA. So the first patient is a 56-year-old female. She's left-hand dominant. She presented at clinic after sustaining a fall while skiing, so a fairly high active individual for her age. So that kind of plays into your treatment as well. But she noted bruising and pain to the right wrist that has not improved since her fall, since returning home from skiing. And so she came into the hand clinic to be seen. So as you can see, Freilich and I share some images since you had the same ones in his talk, but they are important to see kind of where you can elicit your physical exam findings. So on her exam, she had tenderness to the scaphoid tubercle, which is shown here in this bottom image. Tenderness over the snuff box, which is shown here in this top image. Also had pain with a persistent pronation, and her sensation was intact to light touch. So this is the imaging that was obtained on her clinic visit. So you can see a right scaphoid waist fracture. It looks fairly kind of in good alignment here on the AP navicular X-ray. On the lateral, there's no significant scaphoid flexion. So she was placed in a thumb spica splint in clinic, but a CT was obtained to determine the displacement of her fracture.
Yeah, so Michelle, let's stop there for a second. If you can go back. If the faculty that are on want to comment, I mean, it doesn't look too bad there, relatively non-displaced. Anybody that wants to comment on, CT versus not, or operative versus non-operative potential treatment for this, just based on the information we have right there.
So she's 56, but really active. Mm-hmm. If she wants to get back to doing the things she likes to do, I would operate on her and just let her get back out there. In terms of imaging, I'm not sure I would even image it. It does look like there's a gap dorsally, so there's probably some humpback deformity, but you could adjust that at the time of surgery if you needed to. But the imaging is not wrong. I mean, more information is always good, but I'm not sure you have to.
How old is this fracture? Sorry, Aaron.
This is an acute fracture, so within a week or something like that, a week and a half.
I mean, it's a displaced fracture to me. Since this patient isn't that much older than me, then I consider her very young still. So, so I would, active. So it looks displaced on plane, on even the AP. So you know what I would do? Probably fix with 2 screws. So.
Yeah, so just to highlight some of the discussion with this patient before Michelle shows the next slides, but that was the sort of the discussion with her, and she sort of wanted to avoid surgery, and it's generally non-displaced, but there's, you can see on the lateral there, the lunates tilted dorsally, which suggests there's actually more displacement than initially appears. So I think if you glance at this, you might miss that, and you try to treat this non-operatively, and that's one that you get surprised after casting for 8 weeks or 10 weeks, and you're like, why isn't this healing? So she ended up getting a CT scan. I agree that if you're going to fix it anyway, you probably don't need the CT scan necessarily, but it certainly helped with that discussion because it can highlight the degree of displacement and the humpback deformity. So Michelle, if you want to continue.
So this is her CT scan. As you can see, especially on the right-sided image there, she does have a displaced fracture, and it was, on measurements, was 2.5 millimeters displaced, which does meet operative criteria. So she was taken for surgical fixation of her fracture. So I just thought I'd go over kind of briefly of what a dorsal approach would look like. Hers was displaced, so it does require reduction. So the left image is where your incision would be, and then they're marking out Lister's tubercle right there with that dot. And you go through subcutaneous tissue and you enter the third dorsal compartment, which has the EPL tendon in it. that tendon is transposed and you go down to your wrist capsule. And this here shows you the relationship with the scaphoid and the capitate once you do enter the wrist. And then the other two images just show how you would put your K-wire in, what that looks like on fluoroscopy, and really how the screws are angled and all the angles you have to get to during surgery. So these are her final images after her screw fixation and reduction.
So, Bobby, you want to comment on the 2 screws versus 1? So I put in 1 screw, obviously she healed. Would you have tried to put in 2 screws?
Well, so
it fit?
it really depends, but I obviously just had an article come out this week in Journal of Hand Surgery, and I tend to be aggressive. If it's a straightforward and it's a small individual with a small scaphoid, 1 screw's fine as long as you're center, and that's biomechanically stable. But I've gone to fixing many of these with 2 screws because it's more rigid fixation, and depending if it's a high-level athlete, I'd probably put in 2 screws, but 1 screw is perfectly fine too. And in many times during my residency, this would probably have been treated in a cast because it was minimally displaced. But we're a lot more aggressive with fixing acute scaphoids now because treating them when they're non-unions is not easy.
So Bobby, this is Winston talking. Does size matter for 2 screws? I mean, would you do 2 screws in a taller person or a larger person?
Probably. I mean, I would, if I can fit 2 screws in, I would. But some scaphoids are smaller, and it's harder to put 2 screws in. So you have to do a mini open like was done, and take a look at the scaphoid and make a determination. And the location of the fracture too. If it's a waist, you can pretty easily put 2 screws in. But if it's a proximal pole, a small proximal pole, and you try to put in 2 screws, the heads of the screws are large, so you can blow out the proximal pole. So it really depends on the size of the scaphoid, and you make that determination interoperatively. And I think Dr. Freilich sent out the article that has the technique and how I determine whether to put in 2 screws or 1.
Do you end up putting 2 screws the same size, or usually end up putting 1 small and 1 big?
I mean, I try to get 2 mini screws in, but if I have to put a mini and a micro, I'll do that. It'll depend on the size of the scaphoid. So, but if I can put in 2 minis, that would be great. I feel that's great rigid fixation, but it really depends. And if I'm perfectly happy with my guide wire placement, and I put in 1 screw and I feel good about it, and I think it's going to be difficult to put in the 2nd screw, then I won't. But I usually try to put 2 K wires in where I want the screws and determine whether I can fit 2 screws in or not.
Yeah. Great. Any other comments before we move on to the next case? All right.
All right, so the next one is a bit different. It's a 22-year-old male. He's right-hand dominant. He presented to clinic after running into a wall while playing basketball. This happened sometime prior to his presentation to clinic. He had noted persistent right radial wrist pain since that time. He had been wearing a splint after his injury, but his presentation was delayed due to social circumstances. So his exam again, so he had mild swelling to the radial wrist. He did have tenderness to the snuff box. The sensation was intact to light touch, and his wrist range of motion is listed there. And importantly, I think to look at is his limited radial deviation, likely due to some degree of pain or limitation on his exam. So this is his imaging that was obtained on his clinic visit. This is more of a proximal pole fracture compared to the prior patient. Hers was more of a waist. So this is a proximal pole, and as Dr. Freilich mentioned, these require either a long time of immobilization, or they are automatically a surgical candidate due to the location of the fracture, due to the risk of vascular necrosis and non-union from the blood supply. So we further evaluated him with imaging to evaluate the degree of deformity of his fracture. So he obtained a CT scan. We can see it is still displaced proximal pole scaphoid fracture with some degeneration at the fracture site. So options for a patient like this, he's young, he has a non-union, a displaced non-union of his scaphoid. And a patient like this, we at UVA, we typically do a vascularized bone graft. So that's what he went with. And he went with a metaphyseal condyle graft. You can also do grafting from the distal radius, or the 1-2 intermetacarpal, I think, is also another one you can do. But we typically here, if the patient's amenable, do a metaphyseal condyle graft, and that's what he went for. So this is his intraoperative imaging. And I'll go quickly through kind of very basically how or kind of where this came from and kind of how you do the procedure. So it's based on the descending genicular artery. This is showing the medial side of the knee right here, the vastus medialis, and then some local landmarks there. So you reflect the vastus medialis anteriorly, isolate the vessel here. And then this is a technique to isolate the bone graft, which is typically in this shape with the pedicle attached. And then that's what the pedicle would look like prior to implantation. And then this is the volar approach. Our first patient was a dorsal approach. This is a volar approach to the wrist. You go along FCR and of course up along here to get access to scaphoid. You move your FCR out of the way, go through the base of the FCR, and then you're at the volar wrist here. And so this is showing the bony defect in this paper that described the technique. So this is where the bone graft would inset after you've debrided the AVN or the callus or whatever happens to be at the non-union site. And this is an example of the degree of kind of microscope work that's required for this anastomosis. So here's the venous anastomosis here on the figure A on the left, and then here's the pedicle artery insetting into the radial artery on the right. So this is our patient's final images here at his most recent follow-up. I believe he followed up last week with Dr. Freilich. And so we'll follow him out long-term to get more images, but this is his most recent follow-up about a few weeks after his procedure.
Good. So just to comment on this, and then we can go back to the injury films and kind of discuss vascularized bone grafts. But he had a medial femoral trochlear graft, so a little different than the medial femoral condyle graft, but the same artery. And so because of his proximal pole, which you can get a sense on the CT scan, and as you look through the different scans, the proximal pole is actually fairly cystic and probably even fragmented, which is exactly what we found in the OR when we looked at it. But at that point, it's going to be hard to salvage it with any kind of vascularized graft, and including the proximal pole, no matter how you put the screw in or what kind of K-wires you put in. So that graft from the knee actually includes a cartilage surface, so the surface that's pointing down towards the radius here now is cartilage bearing from the medial trochlear aspect of the knee, and again along with the blood vessel attached. So that's why there's only one interface and one screw, and that's what we did for him. So again, you can kind of get a sense that there's some fragmentation of that proximal pole, different from when the original injury films were taken. But for these bad proximal pole fractures that are chronic non-unions or have been operated on before, it becomes very challenging to do a lot of these other vascularized grafts. And so in conjunction with our plastics colleagues, we've started doing some of these free vascularized grafts and had fairly successful results with healing, especially these trochlear grafts where there's only one interface. They tend to heal actually very rapidly within 6 or 8 weeks sometimes, which is obviously very different than most of the scaphoid fractures that we expect to take at least 3 months. So if you want to go back to the injury films, the previous films, Michelle. So obviously that's not the only way to treat these. So if the hand faculty want to comment a little bit about options and maybe what you guys would do for this.
Yeah, happy to comment. So this is a 22-year-old, right?
Yep.
And it's been how long?
It was 9 months or a year or something like that. I can't remember.
Yeah, it's a proximal pole, so high risk of AVN. So a vascularized bone graft is an option too. A pedicle graft from the distal radius on an artery. So you can take a pedicle graft from the the radial aspect of the distal radius and put it into the non-union site and put a screw in. But you got to correct the humpback deformity, or there's a high rate of not healing. But if there's significant AVN, what I think what's being shown is that the procedure you did has probably a more reliable result. I've done plenty of these pedicled vascularized grafts over the years, and a lot of them you think they're going to heal and they still don't heal. So excising the avascular portion and replacing it seems to have a higher healing rate.
Aaron, when you totally excise that and replace it, is there any longitudinal study that shows wear patterns and that sort of thing?
I don't think there is yet. Jim Higgins has done the majority of these and has done a bunch of studies, and he's starting to publish some kind of shorter and intermediate term results, but nothing that's really long term. So that's a good question. You're taking out the scapholunate ligament potentially, as well as the proximal pole, and putting obviously a little bit of a wonky shaped graft in there. And does that make a difference, and do they tend to get arthritis anyway? I think that's a good question. I think time will tell as to whether or not that's better than a snack wrist or not. The idea is to overstuff it a little bit. It stands the scaphoid up and prevents it from falling volarly, even though you don't have a scapholunate ligament. And at least in the short term, that seems to make the difference. But that is a very good question. I don't know what will happen, but I guess in 10 years we'll know. So we'll see.
I'm glad you guys are doing those. Dacus taught me the base of the index metacarpal vascularized graft, basically. I've gone to using that instead of a 1-2 ICSRA. I mean, it's just super easy to find, easy to isolate, easy to swing around on this pedicle, and not as tenuous. So that's what I've started using. But, and then you taught me about putting an anchor in the base just to, secure that. So, yeah.
Yeah, I think that's a good option. I agree with you. I think I started doing the 1-2 ICSRA just like you guys did, and it's this futzy little artery, and I don't know if it's intact by the time you get it in there, and you don't get a great piece of bone. And so I don't feel very good about that. So I haven't done that in a while. So I like the idea of the first metacarpal or some other pedicled graft if you're going to do that. Certainly that's, this is a six hour case versus, a 2-hour case. So that's a little bit better from that standpoint. The issue I have with the dorsal grafts in somebody that has bad humpback deformity is that it's hard to correct the humpback from the dorsal side. I think that's 100%. Challenging.
Yeah.
So you have to make sure that you get the humpback corrected when you're insetting the graft from the dorsal side. So that's, I think, going volarly, I find it a lot easier to do. And certainly if you're going to do an MFC or an MFT from the volar side, that seems to help.
So if this was an older individual, sorry, Nicole.
No, I was just going to say that's very interesting.
So if this was an older individual, or this non-union was 5 years or 7 years old, and there was arthritic changes, because there's already, if there was arthritic changes, then your options would be more arthritis operations. So, Michelle, what are the 2 arthritis operations to consider, or 3 operations to consider if they have a chronic non-union of the proximal pole with AVN and arthritis, so a snack wrist?
PRC.
All right, Winston got one
Good
of the
job,
3.
Winston.
Hey,
You got one of the 3. What about the other 2?
How your
Four-corner fusion.
but you can do a PRC if your capitate cartilage is intact. You can always opt for a scaphoid excision, a 4-corner fusion, or you can do total wrist fusion if they have disseminated disease across all their carpal RTC.
Very good. Very good.
So what would worry you in terms of this patient doing a scaphoid excision, 4-corner fusion? Do you like where his lunate sits, his or her lunate sits?
No, it's already sublunar.
Yeah, right, exactly. That would make me a little bit nervous doing a 4-corner fusion.
There's a question from the audience about patella instability, whether you guys care when you think when you're harvesting from the knee.
Well,
I know nothing about it. I'm going to let Freilich answer it.
I figure once we're done with the patella, once we got the graft, that's your problem, Winston. So you just have to fix it. I think it's an interesting question. I would be a little bit concerned if somebody had chronic patellar instability. not so much because of where you're taking the graft or whether that's going to create instability. You don't really have to do anything other than just barely enter the capsule at the supremedial aspect of the knee. But I would worry about chondral changes and other problems that result in you transferring bad cartilage to the wrist. So I would definitely think about that before I would take a graft from the knee for that. So that's a good question.
Good stuff, my friend.
All right. Any other comments before we move on to the next part of this?
Yeah, that was awesome, Dr. Freilich. Michelle, thank you so much for putting this case together. Thank you to the hand faculty. You know, this is one thing. The reason why I wanted to highlight kind of our faculty and residents in this forum is that the collaboration between faculty members and among faculty members is outstanding. I think our residents really benefit from it. So, Aaron, I really do appreciate you putting all that together for me.
Of course.
So now I think we're going to move on, and Cara Thorne is going to give us a tour of Ivy Mountain, which is actually kind of cool because Ivy Mountain is still being built, and it's probably a good opportunity for her to be able to see what all the fuss is about. So, Cara, are you there?
Yep, I'm here.
Awesome. Well, Cara, give us a quick tour, and then I know Dr. Chhabra has some comments as well, and we'll
Sure.
finish the whole thing off with the Q&A with Dr. Chhabra. All right?
So these are slides that Dr. Chhabra put together. This is his labor of love, so I'm just giving the commentary right now. But so this is a presentation about Ivy Mountain, which is set to open in January 2022. You can see a kind of an artist rendition here of the building. It's going to be quite a beautiful building. The goal of the partial goal of the department and also of this facility is to provide the best patient care for our patients and to educate the next generation of physicians and providers. And so I'll kind of go through how the setup of this building will meet that goal. So first of all, you can kind of see what this building will contain. And so one of the ways this will help give us an ability to provide the best patient care is that you have kind of a one-stop shopping trip for all musculoskeletal needs for a patient. So that's accessibility. So if you think about if a person is polytraumatized, they have a spine injury, they've got like a lower extremity, upper extremity injury. At this point, they kind of have to go to 3 different clinics. But with this setup, they would be able to get all their appointments in one single building because we have all those amenities available to them there. We're also, you can see here with respect to the sports center and the spine center, especially, that it's going to be multidisciplinary with respect to the fact that physical medicine and rehabilitation will also be on site to help with some kind of the medical musculoskeletal needs. And also you can see here in the hand center, we currently have this at our current hand center, but hand and occupational therapy is right on site. And there's also a wing for physical therapy that would be available on site. So definitely all your needs in one place. This is a aerial view of the site prior to construction beginning. What I kind of like to highlight from this slide is that you can't really see it in this picture, but just down the road are all the sports complexes. So our baseball stadium, our football stadium. And another way that this facility provides the best patient care is that we'll have extended hours with MRIs on site. So if an athlete is hurt at practice, they can come to the facility and get a diagnosis and potential treatment then, rather than having to go to the ED. Another thing I like about the slide is it just shows the abundant greenery of Charlottesville. So it's a really nice place to live that you can just tell from this slide. This is the floor layout for the building. So just some things to highlight is that my understanding of the 90 to 96 clinic rooms. There'll also be 6 ORs, 2 MRI scanners on site. And then you can see here noted in the ground level that there will be physical therapy on site. There's a really nice area out here where there's actually an ability to do outside exercises with the patients. There's kind of an outside physical therapy area. And also within the building, you'll notice that there are multiple conference rooms and actually a dedicated resident workspace. So that's another way that we're trying to reach the goal of providing the best education to generate the next generation of physicians. A few more artist renderings of the building. So you can see from all these views of around the perimeter of the building, that there is a lot of windows, a lot of light. It's going to be a pretty beautiful building. So kind of going to the nitty gritty a little bit more, you see all the floor space for the physical therapy unit. In addition to having this large area for physical therapy, there's also, we'll see in a few slides, that the patient rooms are rather big too. So a big point of this building was also to allow for same-day joint replacement. And so people would be staying for at most a 23-hour of observation, and their rooms are large enough that they can do physical therapy in their room and have their families around to see how to take care of them after joint replacement. So also another boon of the facility. Another kind of artist rendering of the operating rooms. This is what I was referring to with respect to the patient room. It's rather big, rather spacious, can accommodate physical therapy and a staying place for people to stay with their families in the future. You can see us walking in the lobby here, talking about that natural light, wide open spaces, check-in area for the patients. This is the front of one of the clinics, so this is specifically the joint clinic, but most of the clinic entry areas look this way. Here to artist rendering of what the floor plan for the sports medicine clinic will look like. You can see that most of the kind of the administrative areas are set to one place, with the patient area set to another. So currently, patients walk by and they see us doing our paperwork, and they really don't need to see that. So they'll be kind of separated where they are streamlined from the registration desk back to their room. And then there's some, in the back area of the clinics, there's some overflow rooms. So sometimes clinic gets slowed down if, we're working a patient up for surgery and then someone needs an injection, and just rooms are kind of getting clouded up with people, and we can't get patients back for their appointments on time. So we have overflow rooms in this new building that would prevent that from happening. The next few slides are just showing the kind of what the front of each clinic would look like. So this is for sports medicine. Then another floor plan for the hand center, fairly similar to the sports center that we talked about. Front of the hand center. This is kind of looking from the back of the building in. So you can see that joint replacement, trauma, and sports medicine will be on the first floor of clinics, and then right above that will be the spine center, foot and ankle, and hand. And then coming off on towards the right of the screen would be the hand occupational therapy center, which would be connected to the hand center to allow for patients need specific therapies, they can get it the same day instead of going elsewhere. Kind of a rendering of the exam rooms, very spacious also. So this is kind of getting into the more, not just the artist rendering, but actually what's happening. And so the old KCRC factory had to be demolished prior to starting construction for the building. And this is just a slide highlighting Dr. Chhabra, I believe giving opening remarks for when groundbreaking occurred. And so this has been a 10-year process for Dr. Chhabra to get the building off the ground, and quite the project. It's going to be pretty amazing. Aerial footage of construction beginning. So this is the main road which you turn off to get to the building. It's Ivy Road. This is the front of the building. Over here is where you'd have your outpatient physical therapy area. Here, we might be able to see it in a few more pictures, is kind of an outdoor garden terrace area. Food services will be back here, and there's an outdoor patio for people, large parking deck. And then kind of on the back end here is where you would see all those clinics that we just looked at. Kind of another aerial shot there. More aerial shots. And then these are ones, I don't have a drone or ability to get aerial photographs, but these are some shots that I took most recently on last week when we went around the building. So again, you can just see this is kind of the outpatient physical therapy area. See all the abundant light that's allowed to enter the building. And then this is a view from the back with the parking deck, and the clinics will be right here. And over here would be where the conference rooms and educational center would be. Just as a side note, the UVA health system completed an addition to the hospital. This building under the big arrow is the bottom floor is where the ED is, and then there's new inpatient units. We were supposed to move on to the third floor to have single patient rooms. the COVID-19 situation kind of threw a wrench in that, but I'm sure we'll get our spot in the new building quite soon. And that's all I got.
Great. I just wanted to thank Cara for that presentation. Yeah, this building was approved. I was able to get it approved in 2009. So you see how fast things move in an academic center. But it took quite a bit of time to get approvals through the boards, to get the architectural plan, as well as the construction teams and everyone hired and everything approved through city council and through county permits and so forth. But we did break ground in 2018. And as of now, we're close to being on schedule. COVID is causing some delays in some of the construction and some financial headaches, but overall, we're still, you can see how beautiful the building is, and it is should open sometime in the spring of 2022. It does have it's planned to have 95 rooms with one additional pod, which we can expand into, which will be an additional 10 rooms. My goal is to move Peds Ortho there in the future from the Battle Building, the Children's Hospital, which is next door to the main hospital, but we just shelled out a pod. We will open 4 ORs there and we'll shell out 2 additional ORs for the future. The place was designed for our high-level athletes and sports surgeries, but the biggest focus in the ORs will be outpatient joints, so hips, knees, shoulders, ankles, elbows that are 23-hour stay, as we don't have a 23-hour stay unit in the hospital. So we're doing those cases in the main OR and clogging up the main OR and the hospital. So this the 23-hour stay unit was designed particularly for 23-hour stay joint replacement, which is becoming very common. We'll still operate our inpatient services will be in the main hospital and our new floor eventually when we get it back. And we'll still continue to operate at the Battle Building, which is the outpatient surgery center, where there's 12 rooms and ortho does between 40 and 50% of the cases over there, depending on a given day. So we're a tremendously big part of UVA. I didn't get a chance to give an introduction, but the last 5 years, we've done more inpatient and more outpatient surgeries than any other surgical service at the University of Virginia Health System. So we're a growing department. When I started as chair, we had about 19 faculty members, and now we have over 30. So we continue to grow. And of course, the health system has realized the growth potential in orthopedics, and I've been able to work to acquire more resources and space over time. And although it's taken a long time, when it does open, I think Ivy Mountain Orthopedic Center will be the best facility in the country. And we really took care not to just make it very patient-centric and patient-friendly, but also provider focused, so that it's a great place to work. All our administrative offices will move there. There's a resident conference room, a dry bioskills workshops. There's a community conference room that can seat up to 200 people. Who knows how much they'll seat during COVID, but it can be divided into 3 conference rooms. There's plenty of meeting space. There's a collaboration hub for collaboration. The clinical trials teams are also in the clinics. Their offices are in the clinics. Our PA offices are in the clinics. All the faculty and all our business team members and administrative staff are also in the center. So it's really a wonderful facility. I traveled to 8 different facilities over the years, orthopedic centers, and tried to bring the best of every one of those facilities, including HSS and Utah and Missouri and Ohio State, Andrew's clinic down in Pensacola. I tried to bring the best of those clinics to this clinic when we were designing it. So it's a beautiful facility, very proud of it. And I think it will really advance not only the care we provide, but the education we provide and our community outreach. And I was able to acquire the land right next to the athletic complexes, JPJ Arena, and our baseball and softball fields and lacrosse and soccer fields. So it's literally a stone's throw from our athletic complex. So it's going to be very convenient for our UVA athletes as well. So thanks, Cara, but it's a wonderful place, and I'm very excited about the future of the department and the resources that we'll have for caring for patients and for education, as well as clinical research.
Thank you, Dr. Chhabra. That was excellent. So I think I can speak for all the faculty and residents, both on this call and not on this call, that Dr. Chhabra is kind of who drives the program forward. And if you can't tell the momentum that we have here, it's pretty impressive. And so just this Ivy Mountain expansion we're doing, that alone can kind of give you a sense of where UVA orthopedic stands within our hospital system. And I just want to say thank you to Dr. Chhabra for kind of being the quarterback of our team and guiding us through this process, because I was a resident here at UVA, and when I was under the impression that Dr. Chhabra can become the chair, for me it became a no-brainer to come back here on faculty, because really honestly, it's when you have somebody like that leading your ship, you know you're going to be going to some pretty cool places, and I think Ivy Mountain is just an example of that. If I could borrow you again, Dr. Chhabra,
Sure.
If you could just kind of give us your vision for the program, just to the people who are listening to this lecture, just kind of your vision for the overall program. I think it'd be helpful to kind of see where we're going with all of this. Can you give us 5 minutes of that?
Sure, absolutely. My goal, I did my med school and residency here, and I started on faculty in 2001, came here in 1991 for medical school. So it's almost 30 years now, other than my short time away for fellowship. So Charlottesville's home, UVA's home. My kids were born and raised here. My wife's a physician in the community as well, and also trained at UVA. UVA is where the only job I've ever had. So, and to me, as everyone who knows me, I'm an incredibly competitive person. I want us to be the best. And when I mean be the best, I mean not only be the best when it comes to clinical care and quality of care that we provide, but be the best in education and be the best in musculoskeletal research and advance our specialty. So as I often give in the introductory speech to when we have on-site interviews, is that it's 3 different circles: education, research, and clinical care. And you can provide great clinical care in my mind, but you have to be able to provide great education as well, because if you don't provide great education, you're not providing great clinical care. And if you don't do musculoskeletal research, and we have a research requirement for our residents, if you're not advancing the field, then how do you know if you're providing great clinical care if you're not analyzing your outcomes? So to me, those 3 circles, they overlap, and if you're going to be the best in all 3, then you'll be the best in the country in your specialty. So I'm always constantly, I think, pushing everyone around me, but particularly pushing myself to continue to improve our clinical care, improve our patient access, improve the patient experience in our clinics, improve the physician and provider experience in our clinics, really advance our research program, basic science, clinical trials, as well as motion analysis and human performance. And then with Dr. Guafmi at the helm, with Dr. Bachman, really elevate our educational program by incorporating simulation. And we have a fresh tissue cadaver lab that we can really use very frequently to train our residents and fellows, simulation into our curriculum, and enhancing our curriculum to make it as strong as possible. So, to me, I want to be the best in all 3 areas and all 3 of our missions. And our mission statement is to be a world leader in clinical care, education, and musculoskeletal research. So that's my vision. You can only do it if you have the right people working together, and if you have the right resources and right facilities and the right team. So everyone's got to be rowing the boat in the same direction, and if we're going to accomplish this goal. So I hope those of you who want to push yourself and want to be the best, consider us, because I think that's where we're going to end up very soon.
Thanks, Dr. Chhabra.
Yeah, I see some questions. That's great, Dr. Chhabra, and you're amazing at leading us and having us all row in the right direction. There's some more specific questions. Winston, the first one, maybe you can answer the best.
Well, just tell everybody on the call that we are going to have a PD session, a program director session. Dr. Bachman and myself are going to spend a lot of time answering any questions about curriculum and rotations and whatnot. Dr. Chhabra, if you want to comment, I think I can take that question from Matt Miller as far as curriculums and rotation stuff. And we'll go into some more detail. We are trying to expand. We always are trying to expand our program. We're going to try and expand to 6 residents at some point, which will give us a lot more flexibility in rotations. But again, I'll cover that in more detail in a later talk, okay?
So the last question, Winston. So we currently are off-site at Fontaine Research Park for our orthopedic clinic. So we have a hand center in one building, the sports center in one building, the joint replacement clinic in one building. So we're already about a mile away from the main hospital complex. We moved orthopedic. It's very easy for patient access because it's right off the highway, or that we moved there in 1994. We were the first clinical department to move away from the main hospital because the main hospital is landlocked and parking is terrible, and it's not easy for patients and so forth. So we moved there when I was a resident, so 25 years ago. But now that area is starting to grow and more clinical services are moving there. So I wanted us to move to our own site that also had easy access for patients. And we needed a new facility that consolidated all our clinics. So all the outpatient clinics will be done in this facility. And it's only about a little over a mile from the main hospital. So it's very close by. All our inpatient work will be done in the main hospital. Education will probably be a combination. When we have grand rounds and some conferences, they'll be done at Ivy Mountain. But if we have conferences, we will probably have a combination of virtual conferences for those who have to work at Ivy Mountain that day and those who are in the main hospital complex, because we have conferences in the morning. But anytime you're in clinic, and if you're doing outpatient cases with joint replacement and some sports cases, you will be at Ivy Mountain, and the residents' offices will be at Ivy Mountain, the faculty offices will be at Ivy Mountain, and a large part of our educational curriculum conferences will be done there too. But it's about a mile, and it's essentially on campus, so it's not far, and it's a very convenient drive.
Awesome. Well, it's getting close to 9 o'clock. I know is your chance to ask the chair any questions. Again, like I mentioned before, I will do a program director Q&A in the next couple of weeks. I'm trying to figure out kind of which conference to tack it on to. So any other questions for Dr. Chhabra? I want to apologize for kind of being a little in and out here. I'm actually on vacation in North Carolina. I'm trying to run this with my family and a bunch of kids running around, so we're doing our best. So thank you to the hand service. That was awesome. I learned a lot about scaphoids. My dad's a hand surgeon. I'm down here with him, and he was actually tuning in and talking about what he would have done in some of those cases. A lot of it which involved using some type of cast. Anyhow.
So Dr. Gwathmey's father actually did his fellowship here at UVA. He's one of our alums, and one of the biggest heartbreaking moments of my life was when Winston came up to me as a resident and said, "I'm not going to do hand, I'm going to do sports." And that cost me. So.
I apologize, Dr. Chhabra. So yeah, hand is a very appealing here. If you look at our alumni from UVA Orthopedics, you'll see a very large proportion go into hand surgery, more so than the average program in this country. And I think it has a lot to do with the hand faculty here. At each year, the sports division, the hand division, kind of fights over the best and the brightest. And we got Michelle Q to do sports. A lot of our best and brightest have gone to do hands, so it's always a big competition. But thanks to the hand division. So next week will be, thank you, Dr. Chhabra. Next week will be the foot and ankle division will be highlighted, and we'll be doing a talk on posterior tibial tendon insufficiency, and we'll cover some other topics about UV orthopedics. So thank you, everybody, for being here. Like I said, I like to keep it 1 hour each time, and so I think we're right on time tonight. So good job.
And
all right, guys.
Thanks,
Thank
Dr.
you, everyone.
Gwathmey.
Thanks, Winston, very much.
Thank you.
Freilich, Michelle, and Cara.
Have a wonderful evening, everybody.
Night, everybody.
Good night.
Good night.